My name is Wayne Oliver, and I'm the Executive Director of Patients for Fair Compensation, an organization dedicated to changing the dynamics within the current medical malpractice liability system. Thank you for joining today's program, which is entitled Current Problems with the Litigation System. Michelle Mello, who is an expert in patient safety, formerly at Harvard and now at Stanford, indicates that the problem with the current system is that it helps very few individuals that it's intended to help, and that in the process it hemorrhages tons of money in the process. And then lastly, it has some significant side effects which are adverse and painful for the healthcare system. So what are those painful side effects? Well, first, there is a legitimate access to justice under the current system. Less than 20% of all injured patients actually receive any compensation whatsoever, and less than 1% of those individuals that file medical malpractice lawsuits ever go to a jury trial. Secondly, there's a problem of defensive medicine. 26% of all overall costs have been attributed to defensive medicine by a survey of physicians by the Gallup organization. Hospital administrators indicate that 34% of all hospital-based costs are the result of defensive medicine. And each and every state in this country is spending and wasting billions of dollars each year on defensive medicine. And third, so long as we have a shame and blame system, we're going to have a hurdle for patient safety and developing protocols and systems that will help eliminate those injuries in the future, which is why we created the patient compensation system. Originally, it covered all healthcare services, all healthcare professionals, and all healthcare facilities. It was developed on a process, an administrative solution that was similar to workers' compensation in the way it was designed to work. However, opponents lined up in opposition of the bill. The trial bar was most vehement in their opposition, but they were joined by the defense bar. So lawyers on both sides of the issue were opposed to the solution. And medical professional liability carriers also opposed the solution. So we started listening to physicians, listening to injured patients, and listening to employers and health plans on developing the process from the original version to what we refer to as the Patient Compensation System 2.0. After listening to those physicians and employers and injured patients, we realized that more and more overall healthcare costs are being shifted away from health plans and onto the backs of patients. And as a result, more and more defensive medicine and more of those costs are being picked up by patients. So what happens in the rest of the world? Well, physicians simply don't practice defensive medicine. And not all American physicians practice defensive medicine. However, 82% of them do. And so why do they practice defensive medicine? Well, we're the only physicians on the planet that are held personally liable for judgments in excess of policy limits. So let's look at the overall healthcare spending as it relates to medical malpractice costs. Less than 11% of premium dollars, 11 cents on every dollar, goes to the injured patients. The rest of the funds go to 30 cents on every dollar go to defense attorneys. 30 cents go to insurance company profits. Trial lawyers get 12 cents out of the equation, and the administrative costs are about 17%. So the current system, designed to take care of injured patients, returns less than 11% of those premium dollars to that injured patient. Recently, a study was conducted by Joanna Shepard-Bailey, an economist at Emory University, indicating that the business model of the trial bar also limits access to legitimate health justice. More specifically, that malpractice attorneys required economic damages in the area of $350,000 to $500,000 just to be able to take a malpractice case. Over 80% of all of those folks who are legitimately injured fall well below that $500,000 threshold. And lastly, for anyone who is poor or old, on Medicare or Medicaid, who's out of work, those folks have no economic or diminished economic value, and as a result will never get their injuries compensated. So let's talk about how the patient compensation system works. I recently had my right knee replaced, so let's use the example of my surgeon replacing my left knee instead of my right. So at the point of injury, at the point where a patient is otherwise injured, a patient advocate is appointed. That individual will help that patient navigate the system, help point them in the right direction, show them how to file a claim with the patient compensation system. Once that claim is filed, it is reviewed by a licensed physician who is the chief medical officer for the patient compensation system. That individual gathers all of the pertinent information, interviews all of the folks that were otherwise present, gets a medical record from the provider, and ultimately appoints a panel of experts to review a redacted case file. So once that medical director has made a determination of the prima facie ability of an injury, that independent medical review panel will be appointed. Those folks are pre-approved from a panel of medical experts that are specifically within that specialty of the surgeon. In my instance, that would be an orthopedic surgeon who operated on my knee. The physicians on that panel, there would be 3 of them, would review a redacted case file, no patient name, no doctor name, no hometown, no facility, no hospital. It just indicates that this patient was otherwise injured by an orthopedic surgeon. And then they will go through a series of questions that will lead them to a question, was this a medical injury? If it was, then the injury is compensable. If it's not, then it's not compensable. There is a matrix that those physicians will be using to determine what that liability otherwise is. If the panel determines that that injured patient in fact did sustain an injury, that patient is eligible for compensation. That compensation will be developed on a schedule which is based on historic payments for that particular injury and the severity of that injury. Those awards would be based on historical data. The beautiful thing about this solution is it has access to 35 or 40 years of actuarial data as to what wrong site knee surgeries would otherwise provide. And the total compensation may not exceed that which is collected from physicians. If there are problems with substance or process, patients and physicians can appeal that determination by that medical panel. Questions that are raised as it relates to the amount of compensation are not subject to the appeal. It is just strictly, did we follow the process correctly when that determination of a medical injury was made? And lastly, on the backside of the solution, there is a quality improvement entity that will look at all of the data that is submitted to the patient compensation system, begin to develop best practices, and then share that information with physicians and other clinicians to help improve the quality of care that is provided. So let's talk for a minute about the Patient Compensation System 2.0, which is a little different than the original version that was introduced. There were 3 objections that physician groups gave to the original version of the patient compensation system. They believe that paying more compensation to more patients will result in increased cost of malpractice, it will result in increased claims to defend, and third, it will result in increased reporting of physicians. So we'll look at all of those in just a minute, but let's talk about the benefits of a PCS System 2.0. First off, there is no claim to defend. There are no lawsuits, there are no depositions, there's no hearings, and physicians will not have to appear. There is no personal liability for malpractice. Unlike the current system where payments or judgments in excess of policy limits can be routinely made, sometimes referred to as jackpot justice, that can't happen under a PCS 2.0 system. There is no reporting to the National Practitioner Data Bank. It is a state-based fund with a criteria from the National Practitioner Data Bank that indicates that, number 1, the claim must be submitted in writing, number 2, that it's based on negligence, and number 3, that there is an insurer that is involved that makes a payment to a patient on behalf of a physician. Under a Patient Compensation System 2.0, there is no written demand for payment. Claims are submitted orally and are provided to that chief medical officer for examination. The second is it's not based on negligence. It's based on avoidable harm. And number 3, there is no insurance company involved. The patient compensation system actually takes care of all claims that are made by injured patients. The elimination of malpractice premiums. Your traditional insurance is no longer necessary. Your admin fee will cover you for whatever injuries that may occur, and without any limitations at all. The elements of a new PCS bill include that it is for physicians only. The previous solution tried to encompass all of healthcare practitioners, and all healthcare settings. This focuses exclusively on physicians and those under the direct reporting mechanism for that physician. It's revenue neutral. The bill limits the compensation to injured patients to that what is collected in admin fees from physicians. And it limits the overall increase of those admin fees statutorily, so that only the General Assembly can increase those admin fees and must do so through the legislative process. It eliminates the need for traditional insurance policies, and so medical malpractice insurers are probably not going to like this solution. And then lastly, the PCS system pays all compensation out of those admin fees collected from physicians. State-specific solutions have state-specific answers. So how do we reduce the medical malpractice costs for Georgia physicians? Well, here's a sampling of the current system versus a PCS 2.0 solution. So for a family practitioner in Georgia, almost $13,000 of premium is generated by that physician. Under a new patient compensation system, that would be limited to $3,900. For emergency docs who pay over $25,000 a year just in professional liability insurance, that reduces to under $9,000. Neurosurgeons who currently pay almost $85,000 a year in coverage would pay a PCS administrative fee of $25,000. So what's the impact on Georgia employers and Georgia jobs? Employers and health plans will realize two types of savings. Number one, savings from their health plan, and that is in the area of $15 to $31 billion over 10 years. A PCS system would represent a reduction in 10 to 21% of each individual employee's cost for health insurance. And with those proceeds, jobs in Georgia could grow by 25 to 40,000 a year. So what's the impact on the state of Georgia? Two actuarial studies confirm, both one by Aon and the other by Bioscience, and peer-reviewed by a professor at Emory University, indicates two things will happen. Number one, there will be a significant decrease in the cost of malpractice, and number two, there will be an overall decrease in healthcare costs. The net savings to the state of Georgia, $3.1 billion to Medicaid, $3.8 billion to the state employee health plan, resulting in almost $7 billion of savings for the state of Georgia taxpayers over 10 years. So can we afford the status quo? In 2012, over 9 million Georgians paid $14 billion in defensive medicine so that 16 medical malpractice juries could be impaneled to compensate 3 injured patients. If you have questions, please send me an email or give me a call. We'd be delighted to answer your questions, to speak to your specialty society or your county medical society. We need physician adoption of this solution for it to be successful. Thank you for participating.